I think we have Professor Prasun Chatterjee with us. Professor Prasun Chatterjee is a senior professor at the Department of Geriatric Medicine at AIIMS, and he's a very renowned clinician researcher from AIIMS. May I ask Professor Prasun Chatterjee, sir, please unmute yourself if you want to have a comment on.
Oh, thank you. No, I'm sorry. I joined late. As usual in AIIMS, it's always in clinic. Clinic to basic is little difficult, but always in clinic. No, I heard few last opinion of Dr. Subhadrach. I think he's doing a great job. I just mentioned about I'm also working with mesenchymal therapy for frailty and dementia. So yeah, I'd love to get connected with you. I'm also sifting for the same work with from AIIMS to some other hospital for this purpose only, because I'm keen to explore the possibility as much we can, because frailty, dementia, sarcopenia are something we just say it is like age-related changes, nothing much can be done. That is the worst answer as a doctor we give to patient. What we don't understand, we say it is age-related changes.
Yes.
So so there I have lot of interest, and fortunately I'm getting good researcher to work with, and we have a good dedicated lab where we are planning to extract all this and work on it. Many disease has been explored, obviously, just like the thing you mentioned about heart failure in pressure sore and other things, but frailty, one trial of course has shown phase 2 trial has shown a lot of promise, Kratos trial I think. And then so we are working in the same model, and I'm also trying to get connect with some condition media if we can improve the quality of cell, quality and quantity of cell. So
Yes.
I think today there are other speaker also, but so I'll not take much time from it. But if I get your mail ID, I can get connected with you and get your guidance.
Sure. It's SSEN1 at
a second, just
gwu.edu.
I think
I can
Sambo,
share.
you must be having.
I shall share that with you.
So I took a permission from you. Now I can take your mail ID and I can mail you, and I'll love to have and I think it is great that less participants, so there are a lot of interaction.
No, not less participants. We have more than 500
Oh,
delegates
okay.
with us. So
this is for
the faculty link only.
7 faculty.
So we have almost 526 participants
Great.
who are watching us. So once again, we are really thankful to Professor Shen, because your lecture was so important for all of us, because in India, the stem cell research is not growing that much. We have various regulatory hurdles. We'll discuss in our panel discussion, maybe on that. We have Dr. Nandini Kumar, who is an ICMR, ex-ICMR DG. So thank you again, Dr. Shen. Now we are moving towards our next scientific
I'll sign off if that's okay.
Yeah. Thank you, sir. Thank you.
Yeah.
Good day.
Thank you.
So now we are moving towards our next scientific session, and that will be on geriatric research. And I think we had a small discussion how the geriatric population, they are called as clinical trial orphan. And we have a very renowned speaker with us today, Professor Prasun Chatterjee, who is a distinguished clinician and clinical researcher in the field of geriatric medicine. Currently, Professor Chatterjee is attached with AIIMS New Delhi in the Department of Geriatric Medicine. He will tell us how to design inclusive clinical trials, how we can include the neglected population like older adults, and what are the issues regarding innovations, ethics, and evidence generation. Over to Professor Prasun Chatterjee, sir.
Thank you, Dr. Sambo, and I feel you are doing a great job by connecting a lot of people through this virtual media. Nowadays, meeting face-to-face has become very less after COVID crisis, right? And it saves a lot of time for us. Like my slide is visible to all?
Yes, yes. Please make it full screen. Yeah.
So thanks for the opportunity. And first of all, I'd like to say I'm not a great expert of clinical trial for older adult, but yes, what I understand is their problem. For my last 2 decades of experience of managing senior citizen, and many times we feel orphan when we cannot say that we say that we don't have any evidence to do this. So that fine barrier is always very difficult to explain to the patient many times. So it's more of my, as I mentioned, it's more of my experience. And I tell this as ethical blind spot and of not recruiting older adult in usual clinical trial, just like the way we miss many things due to our blind spot. So older adults are often excluded or poor represented in clinical research. It's more than scientific gap. I will say it's more of ethical blind spot. So the problem of exclusion is we often consciously excluded individual with frailty, multimorbidity. Frailty is a cumulative deficit model where people, due to your lifelong um, deficiency in some of other organ, mostly physiological function get reduced, and we have some phenotypic criteria, but still frailty has not get us scored in ICD because of poor model of definition. Similarly, multimorbidity, as you know, multimorbidity is more of rule than exception. So again, same person has hypertension, diabetes, coronary artery disease. Along with them, they had a stroke, they have osteoarthritis knee, and other problem together. Along with that, functional decline or dementia from clinical trials, treating this condition as inevitable consequences of aging. The things what I was discussing, when we don't understand, we say this is a age-related changes, nothing much can be done. Please accept this as age-related changes. So that is a major problem, I believe, of exclusion. And there has been limited treatment, partly due to lack of motivation from both patient as well as from the medical fraternity. Because I believe most of this condition can be treated, and we try to give them some or other treatment, be it pharmacological, be it non-pharmacological. As a result, many key geriatric syndrome remain underrepresented in clinical research, and maybe there is fear of adverse event, which is true, because even in frailty definition also we say any small insult, the person's functional decline will fall drastically. So we have that fear of adverse event for any clinical trial. Polypharmacy, cognitive impairment, regulatory hurdle, which is recently discussed, and sometimes pure ageism. When I recently I sent a patient to a super specialty unit for intervention, cardiological intervention. He has been clearly denied treatment because he is 95 years, even though his functional status was absolutely perfect. And that I gave a note still. So this is pure ageism. Then how can you create evidence when you are not interested to intervene, right? This leads to a situation where evidence we use to treat older is often based on trial that never included them. So it is again a subjective treatment we start in this population. So ethical imperative, we must remember respect for participant, beneficence, and justice. So respect, demand, informed consent process adapted to cognitive or sensory impairment, because we have to understand regarding cognitive impairment, it is like from 60 to 100, it increases exponentially from 0.9 to 7% in 60s to 40% for centenarian. Now we have good number of centenarian also in this country. Then along with that, there is hearing problem, there is vision problem. So still they demand respect, and the amount of time you have to spend to get the consent needs consideration. Same beneficence job means generating evidence that actually helps them to live better. It's not always only theory which is going to help you, or for our learning, it has to give them a better life. Justice requires fair inclusion and should not be at the burden of disease without access to benefit of research. So exclusion is not protection, it is a neglect. So inclusion does not mean lowering scientific standards. It means innovating the way we do research. This is absolutely true for geriatric population, especially someone who has multiple health issues together. So I feel pragmatic trials are known to everyone. It allow inclusion real world older adults with more comorbidity, real life settings, improve external validity and applicability. Similarly, we have to adopt few new things. We have to be flexible, interim modification, making trial more responsive to the heterogeneity of older adults. Because one thing here I have to underline that heterogeneity is too much in older adults as compared to any other population. Because of these various hallmarks of aging, various changes, more you age, more you become heterogeneous. So there is another added challenge which we have to address. Similarly, geriatric assessment tool like CGA, ICOPE at baseline can stratify risk and personalize outcome. We have to decentralize our trial model, uh, either from hospital, even from the community. Maybe we can use telemedicine, remote monitoring, home visit by the research team for frail homebound elders instead of considering that excluding them. So we have to redefine outcome. Older adults, they don't care about their survival. When they come to me, they say, beta, it's like, I have lived my life. Now you try whatever you can do. But one thing, make sure that my quality of life should be intact. My day-to-day activity, I should able to go to loo. I should switch off my TV. I can take care of my finance. I should not depend for that. So please work on that. Focus on that when you are designing something. So about outcome, because till that the outcome is primarily focused on biomarker mortality, but much more important is their function, independence, quality of life, activity of daily living, gait speed, mood, loneliness, caregiver burden, patient reported outcome is equally important. Even nowadays, studies are showing subjective feeling of aging can also be an outcome, and that makes a lot of sense. Studies shown that centenarian has better subjective aging feeling. Subjective aging means they feel they are younger, so they live long. So then informed consent also needs some innovation because they may face hearing, visual impairment, cognitive decline, digital illiteracy. So we have to work on that domain, how to get proper informed consent. We must use simplified language. We are very busy in every space, including in research. And we try to bypass many things. So that is difficult for elderly. We need audio-visual aid. We need re-consent procedures sometimes too. Many times they don't understand, and single shot, you have to give them more time to make them understand. It has to be legally acceptable, representative when needed. So inclusion also means rethinking informed consent. Of course, regulatory push, global momentum is there. Now FDA, EMA now require age subgroup data. Landscape is definitely changing. WHO has declared this decade as decade of healthy aging. So WHO is also pushing more geriatric inclusive research. ICMR guideline now emphasize on vulnerable population, yet we need more implementation at trial registration and ethics committee level. It's still difficult. I also many times I didn't get approval to do even calorie restriction trial for elderly, giving metformin. It needs a lot of hurdle to pass. And every trial protocol should justify exclusion of older, not inclusion. So yeah, and this is an urgent call because we are entering an aging society by 2050. All of us know more than 20% older adults. So we will, like, older population and pediatric population will be same. The decision we make today in clinical trial design will shape the future geriatric care. So at least we should create evidence for 2050, and we have some time for that. We need evidence of polypharmacy intervention. We need pharmacological, non-pharmacological therapy for frailty. Just I was discussing, we need dementia treatment, not only prevention. We need to reverse dementia. We need longevity science, which is my primary area now, and regenerative medicine in real world elders. And I feel this is possible to generate that much evidence when we will do personalized medicine for each and everyone, irrespective of their pocket, and for all. And that is also possible. So yeah, so let's generate evidence for them and with them. So like one trial which I have written now, and I'm working on this sarcopenia treatment, because till that we generically we say exercise, protein supplementation, but let's say emerging therapy is NAD booster. and older adults with frailty or cognitive impairment are often excluded, but they are the one who need it most. That is the fallacy we have to address. Yeah, so we need to inclusive, pragmatic, ethical, and outcome oriented. So inclusive trial are not just about better science, they are about equity. I would like to stress here, because being a proponent of geriatric medicine, I'm a strong proponent of elderly equity, their dignity, they should speak about them. They should decide about research. Even the person has to be part of the research team. That is happening in many places. Then as a clinician, researcher, policymaker, we owe it to this generation, and we build a healthcare system we work in to ensure they benefit from its progress. So more of tokenism to transformation, from protectionism to partnership. They don't want sympathy from us. They want more evidence from equity. Yeah. So thank you. I'm happy to take any question.
Thank you very much, Professor Chatterjee. I think this is very much important for all of us to understand how should we become inclusive to this clinical trial orphan population when we are talking about geriatric population. And I think one issue I just want to ask you, that even we talk about the elderly population, in that population also there are lots of heterogeneity. I think there could be some individuals who are independent old people, maybe 70 or 75 years old, without any disease or with any disease. There could be some independent but having some multimorbidity, or some frail older people, but they are independent. And again, now there could be some population who could be complex, multimorbid older patients with disability, certain level of cognitive decline. And now another group that could be living in some institutional care, multimorbid older patient. So when we talk about clinical trial inclusivity, how we should approach in this each group of patient, because all of them requires inclusiveness in the clinical trials. What is your take on that?
Absolutely. Absolutely, you are right. So that is the thing we are mentioning here, that the point is, with aging, your heterogeneity increases exponentially. It's not only because of your social status, not only because of your multi-morbid condition, but also so now scientists has found out there are 12 hallmarks of aging, including DNA instability, mitochondrial dysfunction, then epigenetic alteration. So epigenetic alteration can happen. Let's say someone is under stress with all same profile, clinical profile. Someone is not under stress. That also changes epigenetic profiling. So we have now enough explanation to say why heterogeneity is increasing amongst elderly people. So if you ask me what is the best way to do this, because obviously we are not in the ideal world, best way would be to assess biological aging of individual and recruit them in the study, which we are planning. So if I get, and we have to now understand every organ is aging differently. So heterogeneity within an individual is also there. So the way, let's say someone who is at the age of 80, the way, or even at my age, at the age of 46, my every organ is not aging in same speed. So we have to have our cellular aging, what we call as biological aging. So more pragmatic approach would be to go for, if we are not going for precision medicine, for layperson language, if I say, your functional capacity should be the criteria which will define an elderly person, which will cut short many of the other heterogenic processes, including financial status, socioeconomic status, educational status, etc.
Very important. I think this is a very revolutionary comment from your side. We have to move from age to biological age, rather than the age is not a number. We need to first consider that. And straight away in all our clinical trials, we are mentioning from 18 to 65 years, we are including them. So this is I think this is a very important thought-provoking statement from you, how we should give emphasis on the biological aging, and regarding with the with respect to biological aging, we should include our elderly population also in different categories. Another important issues when we are talking about trials in elderly population, we know that there is a possibility of multimorbidity, and patient will take multiple other drugs for different comorbid conditions. Now, generally what happen in traditional clinical trials, we exclude those patients who are suffering from multimorbidity. So here is again a drawback for the elderly population. And I think we need to become more pragmatic. And when we are doing research design, especially in this group of people, we should follow the ethos of pragmatic clinical trials, the inclusiveness. So what is your take on that?
Absolutely. Actually, it is very rare to get a 80+% without multimorbidity. Multimorbidity means 2 or more than that. So hypertension, diabetes, ONE is so common, right? So now WHO has come up with a concept which I was also fortunately the part of it. We can assess their intrinsic capacity. Intrinsic capacity is it includes your vision, your hearing, your mood, your cognition, your mobility, your nutrition, like that. So once we have, again, the coming back to it is one form of holistic assessment of your functional capacity. So what matters when we are following a person is their functional capacity, be it whatever may be the reason. Even the point I was mentioning, frailty in elderly, is also a overall functional decline. So functional capacity is, I can say, one of the phenotypic expression of the all 12 hallmark of aging, what we are covering. So hallmark is in cellular level, intrinsic capacity is your phenotypic level. So definitely aapko agar, if you don't get anybody who has no multimorbidity, then will you not do trial on 85 or 60? Even the trial now is going on centenarian. So people are now thinking there is a concept called super centenarian. That means whose brain function is still good. So cognitively, they are still intact. So only one criteria we need to follow in centenarian trial is that their brain function should be okay, so that we can follow them. Their rest of the sensory can be taken care.
Thank you, Professor Chatterjee. So again, you had re-emphasized the need of pragmatic clinical trial, and especially when we talk about clinical trials, we always think about the internal validity, but I think we need to we need to check how we can increase the external validity of those trials. So thank you once again. And I think all of our delegates had been there, and they were being very much benefited by your lucid and informative lecture.